Welcome everyone. Hello, and thank you for attending this panel discussion on trans healthcare. What we're going to be speaking about today is we're going to examine healthcare and how it relates to trans people. It's going to be focused a bit more on the local context, but for people who are not Maltese, we are going to be sharing best practices, what works, what doesn't work, and seeing how we can continue to improve our service to better serve the needs of our community. And to help me with this discussion, first I want to introduce Michelle Celia. Michelle Celia is the nurse who works at the Gender Wellbeing Clinic here in Malta. She joined the clinic in 2018 and is the charge nurse for the clinic, where she coordinates the clinic services and is the main point of contact for the clients. I would like to take a moment to congratulate Michelle, because yesterday she was given the Equality in Healthcare Award for the work that she does in this sector. So thank you from us at MGRM and everyone. The second panelist is going to be Matthew Kirkhope. Matthew is a young trans and non-binary activist who is on the MGRM, the Malta LGBTIQ Rights Movement's Youth Subcommittee. Their activism focuses on trans and gender diverse inclusivity in areas such as disability, education, healthcare, and sports. The third and final person on the panel is Colette Farrugia Bennett. Colette is an activist for LGBTIQ rights who has been with MGRM for 22 years. She is the co-founder and coordinator of MGRM's Rainbow Support Service and has also been a part of the Gender Wellbeing Clinic since it was launched in 2018, where she currently provides family therapy. And finally, something a bit about myself. I am Amanda. I am also an activist with MGRM. I will be facilitating this discussion with these wonderful people. And I hope that within this next hour, we will be able to explore as many things as we can. This is a very deep topic, so we're going to have a lot to say. So, welcome everyone. To frame this discussion a little bit, we need to look at how Malta got to where it currently is. On Transgender Europe's trans rights map, for Europe and Central Asia, Malta is currently ranked second in trans rights. From a more general legislative standpoint, Colette, how did we get to this point?
Okay, so we have to go back a bit of history. First of all, MGRM, although the name of MGRM started out as being the Malta Gay Rights Movement, at the heart of the committee and its network, trans people were always very present, and that is why there was a name change eventually to reflect this. But along the way in our work, although trans people were not consistently on the committee, meeting with a number of trans people, obviously we learned, and some of us had started out not knowing much about what the trans realities are about. Some of us started out with our own identification and exploration of further identifications and gender identity. So it was a process, and it was a voyage that led us to a point where in 2010 we had seen what Argentina had done, which was basically their legislation that was focused on self-affirmation, and we had come up with a proposal for a gender identity bill. At the time, it was Dr. Neil Falzon from Auditus and MGRM who did this, and at the time we had asked the Honourable Evarist Bartolo, who was a member of Parliament in the opposition, to table this bill in Parliament. Unfortunately, it was not in any way ever discussed in our parliament, until then, when there was, as you all know, change in government in 2013, and the second item on the agenda of the LGBTI Consultative Council was actually the Gender Identity, Gender Expression and Sex Characteristics Act, which was then passed in 2015. But I remember that in 2013, I believe, yes, 2013, I had gone to a TGEU seminar in Berlin, where our aim was to look at the legislative, the legislations that were available in our country, if any, and any proposals, and review with this checklist that the TGEU had come up with, which was kind of the golden standard. And I remember looking at our bill that we had proposed a few years before, and which was deemed as quite a trailblazer in itself, but there were a number of shortcomings. So I went back to the council and said, you know, this is a checklist by TGEU, we need to review what we're going to propose. And in fact, that's what led us to then propose the actual GGSEC Bill Act, and with it then came the talk of trans healthcare as well.
Matthew, I turn to you now as a member of the community, because you're surrounded by two professionals here, so your insight is a bit more valuable, I would say. In 2018, we had the introduction of the Gender Wellbeing Clinic. What did this mean to you personally and the community as a whole?
So, once I came out, I knew that I wished to medical transition. But of course, before the gender clinic, the only option was that you go private. And as some of you might know, that going private is very, very expensive. For example, one of the injections for trans masculine people, the testosterone, costs around 150 euros per injection, which as a person, I wasn't able to financially buy the medication. So with the introduction and the opening of the Gender Wellbeing Clinic, it offered me accessibility for me and other people who might not have the financial ways and means to access the healthcare, and also it provided a holistic support for the trans individual that's accessing the healthcare. So not only providing testosterone, in my case, or hormone replacement therapy, but also providing psychiatrist support, social worker, any type of support that you might need throughout your transition. So once the gender clinic was opened, obviously it was a more accessible for the trans community.
Now I turn to you, Michelle, as the person providing the service on the other side. Hearing what Matthew just said, like, how does it make you feel?
Yes. I remember back in 2018 when we opened the clinic, it was very different from the way things are now. I think one of the biggest challenges was to convince and to had loads of discussions and meetings with healthcare professionals, which we, at that time, trans health was regarded as something related to mental health issues. So that was something we needed to work upon, to depathologize trans health. So it needed a mind shift. The law was the point of departure, and there was also the political will as well to fund and provide the resources to do so. And also, I think something that was different from, I've been in healthcare for almost 25 years. When I started nursing, trans healthcare, LGBTIQ was something which was unheard of. It was never mentioned in the curriculum. So it was something which was not only a mind shift in regard to the healthcare workers working within the clinic, but also outside the clinic. Something which was different was the fact that when the protocol and the care pathways were drafted, they were drafted with the civil society and clients themselves. So that it was something which was piloted for the first time, even though at the beginning it created some friction. However, ultimately, after months, we managed to sit down on a table, discuss, and find the best way forward. But I think the law started this, but then it was a bottom-up approach.
If I may, there was something else that happened, was that in 2016, Malta passed the the affirmation law, which basically one could affirm their gender and at the same time depathologized the gender identity, or let's say we do away with what WHO says, with the World Health Organization says, with what the American Psychiatric Association says through their what do you call them? Oh, DSM.
DSM, ICD.
Exactly, the ICD and the DSM, which unfortunately we're still categorizing gender dysphoria as a mental health issue. And this was the crux of the difficulty when it came to the trans healthcare. So there was, as Michelle said, 2018, it started off at the beginning. Unfortunately, the clinic only started in November, but there was a whole 10 months of discussions that we needed to convince healthcare providers that Malta has this law and that this is the law that is prevailing over any other rule book that you might follow as a professional. And this was obviously, I think, the most challenging part in the discussion, especially because I remember the first time sitting around this table that I happened to be there only because my boss at work decided that I'm the expert and sent me, and not because MGRM or any other organization was invited to be present. So it was literally by chance, in my opinion. And I remember being there and looking at people around me, and they were all from the medical, practitioners, and they were all against what I was saying. So thankfully, some people then saw the light and could see that the law was very clear in terms of what constitutes and kind of what are the guiding principles for our clinic.
Thank you. Michelle, I turn back to you. To add a bit on to what Colette just said, nowadays trans status, as the law says, has shifted from being based on dysphoria to being based on identity, what we call self-determination. Has this had any impact on the provision of gender-affirming care?
Yes, it changed the whole outlook of it. First of all, medical practitioners are used to practice with a diagnosis. So in order to convince the medical practitioners, the psychiatrists, that they need to practice without this diagnosis, giving treatment without this diagnosis, was and is still challenging as well, especially with what's going on abroad. We're hearing and listening to stories of some countries that are stopping transgender health, and even though it's not impacting our services directly, it's still impacting our services indirectly, because this is still instills fear in some of the practitioners within and outside the clinic. So the currents are still there, the fear is still there, because one needs to find the balance between, first of all, when you are assessing for gender identity and based care, there is no tool that one can use. So this creates a certain hesitancy within healthcare professionals who are used to have a tool, they measure, they diagnose, and they give treatment. So without any psychometric tool, without any tool that is still not out there, the healthcare professionals may be hesitant. So me, Colette, and the MDT one of our works involves doing a lot of advocacy and, just to continue to remind healthcare professionals where we come from. And there is also the balance between, is this becoming an easy access, a free-for-all services, because ultimately we are giving hormones and medical treatment which have irreversible effects on a person, and they may pose risks as well. So there is this fine balance which is very sometimes hard to achieve. Our aim, ultimately, we have to keep in mind the well-being of the client and the lowest possibility of regret and risks.
Thank you for that explanation. This panel is, we named it Trans Healthcare, the Way Forward. But before we can look ahead of us, we need to analyze our current situation and what's not working, what can we improve on, what are we lacking right now. Matthew, as the person who accesses the service, what do you think are the flaws and limitations of the current system here in Malta?
So it's important to see beyond the gender clinic also. So the gender clinic does offer trans healthcare, but we also access healthcare through polyclinics, hospital, privately. So it's important to see the whole picture. Within the gender clinic, as we always discuss, we always have meetings to see how we can improve. Even as MGRM, we always try to improve the system. But unfortunately, we sometimes encounter instances where we are either misgendered or not understood to the extent that we wish. For example, as a non-binary person on hormones, at the beginning there was a bit of a struggle to understand why I want hormones and why I want to look this masculine, since I'm non-binary and I want to break that gender idea, which for me, taking hormones was a way to express more that I don't have a gender. I'm more comfortable to wear makeup, to wear nail polish, to wear skirts. I'm more comfortable in my body. And it was a bit of a struggle for the healthcare providers to understand it. Also, there is the idea for all medical professionals that when you're transitioning, you're thinking of going to one extreme or the other. You're either very masculine or very feminine. You can't be a fluid on the spectrum. So it's a struggle to continuously explain to people that, yes, I am on hormones, but my gender is still fluid. I still don't want to be that manly man full of muscles or that feminine girl. Like, it's difficult, I understand, for people to explain because we're brought up to put people in boxes. But slowly things are changing, and now I'm on hormones, of course, and it did move forward. Other flaws, for example, when accessing a gynecologist as a trans person that was assigned female at birth, they don't know how our body changes on hormones. Why do we need to continue going to a gynecologist so often? The pronouns they use, for example, you go to a doctor to take your shot and they just assume, okay, you're on testosterone, you're a man. I'm gonna use he, him pronouns. Or you're on estrogen, she, her pronouns. When in reality, you shouldn't be assuming in any context and ask the person beforehand. There are a list of flaws. I mean, it's the whole healthcare system in Malta. So, for example, even people, when I go, for example, to the polyclinic and I need a medical certificate because I'm sick. And they ask you on what medication you are, and you tell them testosterone. You might have a headache from testosterone. Your foot might hurt because you're on testosterone. When in reality, it's not an effect. I've been on hormones for 3 years now, so I'm sure I don't get a headache or I break my foot because of testosterone. So there is also the misunderstanding that being on hormones makes you more fragile and makes you more prone to diseases, which it might happen. Of course, some things might arise, but it's not always the case. Another point on thinking that when you're transitioning, you have to choose one binary. For example, I'm working on getting top surgery, and my idea of top surgery is not having nipples, because men have nipples, women have nipples. I'm neither, so I don't want them. So having the discussion and explaining to the medical professionals why I don't want nipples, it was also a learning curve, and we got there. We're understanding, but it was a bit of a challenge. Also, for example, microdosing. At the start, there wasn't much knowledge. Again, trans healthcare is something relatively new. So microdosing is even something new. So when I expressed the feeling that I want to microdose, it wasn't understood straight away. But then again, with a lot of discussion, research, taking papers with me of research that I found, and yes, I started microdosing. So there are flaws, but we also have people like Michelle and Colette that understand us and are always working to move forward from those difficulties.
Thank you for that list of things that unfortunately are hindering people's well-being. And one of the things you mentioned was you indicated very clearly that even within trans healthcare settings, non-binary people are still quite misunderstood, and there's a bit of a bias against non-binary people because it is expected that transitions tend to be from one end to another.
Yes.
I pose this question to both of our professionals here. When it comes to non-binary people, maybe we can start with Michelle. How do you identify or balance the safety or risk versus what the client is asking for, what they need?
In regards to non-binary, it's something which we are seeing in the last 2 years, mostly the increase. When we started the clinic, this was a natural shift. Many people who came forward were mostly those people who were already socially transitioned, already on hormones. Now we are seeing the younger ones, and the shift to seeing more non-binary persons is not only seen in Malta but also internationally, because people are not identifying on the binary on either side. It presents challenges in practice because, as Matthew said, every case, every client has the needs of his or her own, first of all. However, the SOC 8, the standards of care which we use now, has a whole chapter on non-binary people. One of the greatest challenges is that there is lack of research in this area, especially when it comes to microdosing. So microdosing with hormonal therapy, we still do not know the risks that a person is going to have long term because there is no research. So there is a really fine balance on what the client needs and what we are able to give. The SOC 8 emphasizes a lot on starting with irreversible measures when it comes to non-binary people. Like if a person wants to stop menstruation, first we can give, for example, progesterone pills. And then later on, we consider surgery, which is more invasive and more risky. So we are trying to shift the mindset even within the community, and we're seeing even this shift with the younger ones, the non-binary persons. Recently, we had a lot of clients who are not opting for hormonal therapy. First, they are opting for irreversible measures. The aim is to reduce the risk and levels of regret. Research also is showing that when you take drastic changes, for example, the removal of the uterus or hormonal therapy, there is the risk, for example, of losing fertility. And research is showing that although a number longitudinal studies are showing that people do not regret that they transitioned medically. However, in hindsight, after 10 to 20 years, they are regretting, for example, losing their fertility. So these are things which we need to discuss with the clients and ultimately find a choice which has the lesser risks.
And when it comes to people who, like I understand as a trans person myself, especially when you are starting out, people generally want everything done immediately, like that instant change. You're excited to start,
Yes.
and but sometimes certain requests, especially when it comes to non-binary people, because there isn't enough research, we need to be a bit more careful. Like even Colette, from the support side, when people are disappointed that they cannot get what they would like, how do you soften the blow? Because these generally would be people who feel like the world might be against them. So when the healthcare system does not support as well, there might be a bit of a problem there.
Yes, definitely, excuse me, definitely a reality that we've been facing. And also some young people actually face this kind of barrier as well, not only through the healthcare system, but also through their family. And that is another reality that I often encounter, that you have parents who are perhaps still struggling with the reality, and the young person is, miles ahead. When it comes to parents and their young people, it's about mostly a dialogue. I mean, at least this is what I try my best to engage in with the families. And I think if we had to look at then the other side of it, the young person or the adult who wishes to move forward, and the clinic is perhaps being cautious, again, we need to dialogue. And this is where I think most of our work has been, especially Michelle and myself, have been doing, that in a way it's important that we educate. That is one of our roles. And also to guide the individual in the direction that is, I'm not going to say the right direction, because I am no one, I should not be the person with power to give a right direction, but from our expert opinion and also being guided by SOC 8 and research, because we attend the EPAT conferences, we attend training, so this is one of the reasons why we keep abreast with what is happening, because we need to guide as much as possible our clients in a direction that is safe and that is healthy for them. After all, this is about healthcare that is inclusive of mental health as well, and the person's health is paramount.
What about guidance to other healthcare professionals? Matthew, earlier, when I asked about the flaws, he mentioned that the healthcare system as a whole, so outside of trans-specific healthcare, is not sensitive to the needs of trans people. What do you suggest can be done about that?
In the last 3 years, we embarked on a project, what's called Transform, and us and the Human Rights Directorate. Its aim was to educate healthcare professionals. So we did a lot of training with charge nurses, practice nurses, first liners, clerks, care workers, carers in different institutions. However, and we also created a website, and the website, transhealth.gov.mt, it's especially designed for healthcare professionals, so there is no excuse. Every GP can access the website, which we update regularly, and there is all the information there. The problem is that, not the problem, the challenge. The challenge is that the topic of trans health is contemporary. It's something which is alive, New research evolves all the time, so we keep abreast. And the healthcare professionals also change all the time. We also have a higher influx of non-Maltese, for example, nurses who are working in the National Hospital, who perhaps do not understand certain concepts the way we understand them. So apart from the clinical work, I carry out, and even Colette sometimes, even to counselors in schools, social workers. We try to carry out as much training as possible. However, sometimes, I must be honest, sometimes I feel that even though you give so much training, sometimes it all boils down to internalized homophobia or transphobia. So most of the time, and now, especially lately, we were discussing the need that we re-evaluate the training and we start from the very basics, because nurses, doctors are also human beings. They have their own ideologies. So we need to challenge where this comes from, because the information is out there. As healthcare professionals, we know we shouldn't judge. That is the greatest challenge.
Matthew, as the person who is on the receiving end of transphobia from healthcare providers, do you have any suggestions on how we can improve the system as a whole?
So there's a lot that's already being done. Training is being provided. I think something that can be done is, for example, before they graduate, healthcare providers, doctors, nurses, psychologists, psychiatrists, it's not an option if they choose to study diversity, even for disability, sexuality, religion, race. It's not an option. You're not going to choose which client is going to be sitting in front of you. So it should be mandatory for for medical providers to be taught these terms, the clients they're going to be facing. So that would be one. And also, for example, I encountered it quite a couple of times when I go to, for example, the primary health care centers, where the doctors don't know that there's a special referral form for the gender clinic. And I end up being the person giving a lecture to the doctor who's supposed to be taking care of me, what they should do. So unfortunately, sometimes it needs to come from the person to reach the information, because the information is there, it's present. So at the end of the day, they need to look for it because it's there.
Thank you. Earlier, I asked Matthew about the flaws of our current system. Michelle, from your end, what challenges do you find in providing the most optimal service?
Yes, I am not going to stand here saying that our service is perfect. It's far from perfect. First of all, it has been a learning curve. Where we started in 2018, we had few countries that we could look up to for good practices. Now they're looking up to us for advice. First of all, the resources. When we started the clinic, we needed to identify persons who are going to work in the clinic. Number one, it's not easy to find dedicated people who want to work in this field, and then the training has to be specific, meaning that before I used to work in school health services, for example, I was the charge nurse there. When I used to to organize training, I used to have 15 nurses. I give them the session of training about childhood obesity, for example, and that training would fit the purpose for the whole 15 nurses. In our case, every single professional needs to do specific and non-specific training. The voice therapist, the gynecologist, the endocrinologist, the psychiatrist. So we have different kind of training. Where to find training? To find training, it's very difficult. We have a good relationship with Ghent University Hospital, and we carry out a lot of training with Ghent. However, training is very limited in this field. Another issue is that our team is very small. So, for example, currently we had 2 persons who left the team at once. When you have staff retention, you end up in a position when you have to reduce your service provision, then you have to wait for new recruitment, retrain, find the person, and retrain. So it's not like when you're working in a medical ward, when a nurse leaves and another comes in. It's a very specific field. That is I think, the first challenge. Another challenge is the issue of informed consent. We base our decision on the ability for the person to give informed consent based on self-determination. However, this is on paper it's fine. However, in practice, how can you really determine if that person is understanding you, has the maturity, especially when we're talking about younger persons who are neurodiverse, for example. So we have a lot of different clients, and that is why perhaps some healthcare professionals are hesitant to join our team, because most of the decisions are based on an informed consent. So they feel perhaps it's risky. So I think those are the main challenges that we face. And the sense of urgency that you mentioned. My heart goes out to the clients who are awaiting services. However, sometimes we cannot do otherwise. As Colette said, we are also aware that these clients had been maybe had experiences of gatekeeping before, may have bad experiences with healthcare. So when they arrive in clinic, they come often with a baggage. Then they relax after a period of time until they gain trust of the healthcare system. So as much as we do understand the sense of urgency, it is our responsibility to ensure that every decision taken it's based on the well-being. I have to stress that the medical transition is only a small part of trans health. Sometimes I think that we give it a lot of emphasis. It's only a small part. A person has to be supported at home. A person has to be able to function in his activities of daily living. Self-care, has to know the balances between risks and balances, has to be compliant with the treatment that we give, because often, unfortunately, we have clients who they think that they will come to the clinic, get hormones, and then we don't see them anymore. That is not the case, because ultimately the endocrinologist is responsible for the treatment that the client is giving without knowing what the person's health risks are. And we know that there are risks. However, if the client attends regularly and regular checkups are done, the health risks either can be identified at an early stage, or can be avoided. So,
thank you. You mentioned a lot of things there. One of your points was talking about informed consent. And this is an issue that we hear about a lot right now when it comes to minors, adolescents, and children. Colette, when we talk about trans children and minors, we generally talk about social gender transitions rather than the medical side. But are there instances where medical interventions are beneficial to young trans people?
Yes, there are. That's a short question, a short answer. But the longer answer is that the reality very much depends on the understanding and the level of maturity of the young person, and what they wish for themselves, but also what the parents wish, or whether they're on board and are supporting their child. There have been instances of young people, so adolescents, who accessed hormone blockers and went on until they were 16 on hormone blockers, and then eventually transitioned into taking hormones. And that allowed that young person, obviously, to delay their puberty and the developments. But these are few. And why am I saying these are few? Because what I find is that many times parents are often still very much skeptical about any sort of treatment. They might be accepting to socially transition or to allow their child to explore and understand themselves better, perhaps within the family context, and perhaps even sometimes with extended family and within the community. However, the thought of taking any sort of medication and taking that decision for their child is sometimes a big no-no. And this is, obviously, I understand why parents have this fear, but also let's be very, put our feet on the ground and be grounded about this, because the realities out there are what they are. I don't agree with what is happening in the US and in many other countries, but unfortunately what is being communicated in the media is leaving a huge effect on the community at large. If you talk to someone about what happened in the UK, they'd say, yes, they stopped any access to healthcare, to trans healthcare for young people, because many young people were reversing in their idea of what their gender is. The reality was very different, and in reality this was not the case. But people don't read the actual reports of the whole investigation, but they read what's on the media, and this is what's being posted as well on social media by the far right in Malta, and this is what reaches parents, unfortunately, as well. Parents can also be gatekeepers, and that is, I think, one of the biggest pain, I would say, for that young person. But we've had a number of young people who have managed to, they have managed to gather the support of their parents enough for them to realize that the only way forward for their child is to actually access hormone blockers, and we've seen success out of that experience as well.
We have a young trans and non-binary person here. Matti, what has been sort of your experience in this regard?
So, for sure, first, my transition started socially. It started with my small group, experimenting with different names, different pronouns. At first, I came out when I was 13 as a lesbian. Well, not anymore. Then I came out in 2016 as a trans man, but it still didn't feel as the right label for me. So I continued experimenting. So it was a lot of groundwork was made socially with my friends, with my family, where I experimented how I dress, how I talk, even how I use my voice, how I present myself. So at first, before resulting to hormone replacement therapy, I started socially transitioning. As Michelle knows, when I went to the gender clinic for the first time, I wasn't in the right state of mind, unfortunately. I had a lot of difficult background coming from, and for example, I wasn't financially stable. I didn't have the support that's required for me to start hormone replacement therapy. I didn't have a fixed house, a place to stay. So I had a lot of challenges, and that put me back from starting hormones. So there's also the idea that once you go to the gender clinic, on the first appointment, you're going to get hormones, which is not the case. when you go to the first appointment, you meet the nurse, you meet the psychiatrist, you meet the social worker, and you have a discussion. And they see what is best for you, what's the right fit for you. And after a year of attending the gender clinic, I was able to start hormones, and I'm grateful for the healthcare providers that they saw the needs that I needed to take care of before putting another stress on me, because of course when I started hormones it affected my mental health, because of course your body is changing in ways you never thought they were gonna change. People around you might start to perceive you differently, so they might stop talking to you, might you lose friends. So it's important to first have that support in place before starting your transition.
If I may add, Amanda, because Matthew made a very good point about mental health. Although trans health in itself, it's not a mental health disorder, categorically not. However, I think it's time that we do not shy away from this topic. Sometimes I feel that the word mental health or mental well-being or going to psychotherapy or counseling, the clients feel that we are pathologizing them. However, that's not the case. We know for sure, because research shows and experience shows that the management of body distress will not stop other issues. So if you do not work on other issues before you start hormonal therapy, things might get worse. So I think it's time we should start to speak more on how to help a person to have better mental well-being. Being transgender person, from experience, the stories I hear, in itself, it's a taxing experience. So a person needs that support. Getting hormonal therapy shouldn't be the only one goal, or surgery, the only one goal that a person aspires to have, because it would be a pity. The endocrinologist often jokes about this because he says, I have the easiest job here, because when clients go to him, they are almost set with, they had so many appointments before and the formation sessions and psychiatrists and psychologists, that all he does is prescribe hormones and do the Schedule 5. See the blood test and change the dosages, which any doctor and endocrinologist can do at the end of the day. However, there is a lot of work that needs to be done, so the person is well prepared, and the expectation that a person will take hormones and all other issues will disappear, it is not a reality. It is not a reality.
So, before we end the discussion, does any one of you have any final comments about anything that you want to make?
One last thing I need to say, because this week I saw a lot of hate crime on the social media. I was disgusted as an ally even to read them myself, let alone. I apologize on behalf of those persons, for any trans person who had to read those comments, because it was heartbreaking. Another thing which I noticed was that there is this right-wing shift and religious groups which are speaking about this demonizing trans people. I think it's also about time that trans people and will also start speaking about spirituality. Sometimes we think that trans people are not religious, are not spiritual, and I think with this outburst out there, I think we should speak more about spiritual care, which is also part of healthcare. So.
Thank you very much. We can end our panel discussion here.